So I pass on to Jörg Fegert now, who will present on interculturality and research in the context of psychiatry, treatment of victims and perpetrators, migration, differences in cultural background. Thank you, Jörg.
Thank you, Hans, for that very kind introduction. Good morning, everybody. I'm glad to see you, to meet many of you again here. So my perspective this morning is the perspective of a Western child psychiatrist. And yesterday I got many impressions about your discussions on intercultural perspectives, and I was impressed by many points, but I would start from some common points that are characteristic for the work of doctors, because I think general norms, worldwide norms, are also important, not only in fundamental rights, but also in professional rights, so that people all over the world can trust a doctor. Yeah? So I will have a focus on the profession. And then I will go to the side of professional work with intercultural issues. But I will start with that body of literature and of our old history in professional ethics. And you can take photos, but I also will post my 2 talks today on LinkedIn, so you can download, yeah, if that's easier for you and you can use it. So why I bring that medical perspective in several times here is because the Catholic Church is the world's largest non-governmental provider of healthcare services. So in many fields, religious orders and congregations and associations are working for the health of people. So it's also, if we want to change something in the field of health, there is a worldwide power and understanding and a network. If you remember Peter Beer's example yesterday, yeah, where you can bring together different perspectives. And if we look at the general standards in healthcare, we have principles like respect for human dignity, protection of vulnerable persons, non-maleficence, do no harm, and professional responsibility and accountability in nearly all national and international codes of conduct. And in some way this goes back to the oath of Hippocrates, so thousands of years ago. And these key principles, do no harm. First, do no harm. If you think you might harm a patient, yeah? And then a special respect for the vulnerability of patients and also for the sexual vulnerability. And this is perhaps different with all other professions. From the very, very early times, people knew that we have a privileged access to the body of a patient and that we have to see patients naked. So there was also a risk of abuse. And already in the times of Hippocrates, he had in his oath, into whatsoever houses I enter, I will do so to help the sick, keeping myself free from all intentional wrongdoing and harm, especially from fornication with women or men, bond or free. Yeah? So that is thousands of years old, but it was clear that it's incompatible with the professional attitude to mix sexual thoughts with your professional work. Yeah? And this is very special for the medical field and now also for the psychotherapeutic field. And therefore I wanted to bring in that aspect, that we also have, even if we have different cultures, we have common expectations how a doctor, for example, should approach us. And I want you also to think about the parallel to a priest or other professions. Yeah? What are the expectations that everybody could have? So we have an exclusive focus on patient welfare in our work, and we have these key principles translated in the actual Declaration of Geneva of the World Medical Association, the ICN Code of Ethics for Nurses. So we have a lot of standardized paper, and one might criticize that from an intercultural perspective. Yesterday was said, yes, but in Africa, these international papers, we need our own papers, and therefore I'm thinking it's very important that every medical chamber in every part of the world had their own rules, but they are all based on this very old canon of rules. And there was a group in the US, in a think tank in the US, again, they analyzed the papers from all over the world to find out what are the 4 ethical principles. And you see they come up with the same things, analyzing all the papers from all over the world. It's the non-maleficence, it's beneficence, it's the respect for persons, and it's justice. And then if you go to an intercultural perspective, it becomes clear that justice means also justice of allocation, justice to access. And this is perhaps quite different in my country with a lot of resources, where many people have access to the health system compared to other countries where you have less resources. Yeah? So these principles can adapt to a local analysis, but they are general principles that we should be open to all kinds of patients, independent of race, independent of resources. And these, there's, for example, also a Charter of Healthcare Workers, and you see it's always the same principles. I don't repeat it, but I just wanted to show you that over these years there is a convergence on basic principles that have to be adapted at a national level. And I think that could be also a way for defining violence against children, to have general principles that we all accept, or as was said yesterday, that we agree from our heart, because with our empathy we can feel that it's wrong, yeah? And then we have to decline it for the special situation in a country. I think the vulnerability of patients, regardless of the religious traditions, of the differences all over the world, the vulnerability is the same. If you are sick, if you need help, if your body is in danger, you are in a very vulnerable situation. And therefore we have a general responsibility of professionals and institutions, and I think the Roman Catholic Church could make benchmarks in that field. And I remember one of the first conferences we had in that room when a survivor from the UK reported how she had been abused by a priest in the hospital, as she was there as a sick child in that very much vulnerable position. You can see how important it is that we really have safeguarding also in hospitals, because these patients are very dependent on our help. And there is a common code of shared principles, and I don't have to tell you that you find the motive of protection of vulnerable persons in the Bible, in pastoral texts, in professional ethics, and even the popes referred to health care with this vision. So in some way, not disagreeing with the other talks we had, I say in that field, in some way we have a convergence on basic principles in many, many texts that are interpreted in different ways in different parts of the world. But I also think it's important that as a profession, that we have that background. And that's why it is important, because forms of interpersonal violence in healthcare are frequent. So we have the same forms of abuse of children that we have in families, also in hospitals, abuse and neglect. And we have other forms like financial exploitation of families, patient killings, violence during childbirth, and non-medically indicated restraint and coercive measures. So we have specific risks also to especially psychiatry. And we did a population-based survey in Germany. Ulrike was one of the first authors of that survey, and that showed that my field, child and adolescent psychiatry, has an increased risk of physical abuse, emotional abuse, sexual abuse, and neglect. And that does not mean that we are especially bad men working there, I hope. But it has to do with the length of treatment, because usually in a pediatric hospital, you just stay 1 night or 2 nights in most of the cases, yeah? And the longer time you have to establish a relationships, grooming and all the negative things can happen, yeah? So it has to do with the intensity of the relationship. I don't know whether you know the work of the sociologist Irving Goffman. He wrote about asylums and wrote about total organizations that have their own culture and their own rule. And we talked a lot about national cultures, but we didn't talk about unwritten intramural cultures. And when we talk with survivors of abuse, they often refer to rituals, to things that happened in the institutions that were not written, but that were known and were part of the hierarchy. And in his book, he very much compares convents and hospitals and all these institutions. And I think this thinking is very important, that we also have cultural difference in the outside world and in an institution. And an institution may become blind for some abuse of power because it's so common in the institution. So if we want to have a cultural view, we also have to take into account the view of the culture of the institution. And we have, as I said, specific risks in a medical context because patients don't know whether the thing we are about to do is really medical necessary. If I tell a patient, please undress, usually they have to obey because it might be necessary. But I think we have an obligation to explain to the patient, to the still dressed patient, what we're going to happen. Yeah? So they are in a very, very weak position, and we have to reflect about that and have to take into account personal-related risk, context-related risks, and environment and society. And there we come to the intercultural perspective now. We have these structural risks that have to be taken into account. But when we come to environmental and societal factors, we have in many countries completely different perceptions and responses across cultures to the same issues, and we have different thresholds to intervention, yeah? And we have to respect the modalities you have in several countries, yeah? You can't have a standard worldwide. For example, as a reviewer for scientific papers, I had read criticisms from scientists in Western countries about case studies that should have been published from Africa, and they asked, why didn't you do a brain scan? Yeah, because it was not available, yeah, in that situation. Yeah? And the story was so important that finally we could make it publish, but sometimes we really have a very Western view also on the resources and the way we deal the cases. It also depends on the resources you have in a country. And also, child development is in some way defined worldwide in the same way. We have these phases of very early childhood and we have the developmental phases, but there are a lot of variations. Yesterday we talked about a case of child marriage. So if you think about the differences that still exist all over the world, yeah, about ideas of age of maturity, this plays an enormous role now also with all the questions we have in the internet, because the internet is a big unifier where you need common answers also to risks, and to balance national views and international offers that often come from Western countries is, I think, one of the very big questions. Or, for example, I was not yet there, but I was told about that example from China, where parents travel from Hong Kong to another place to beat their children. You see that there are cultural frictions and reactions to changes, yeah, that are provoked if you want to introduce change only top-down. Yeah? You need to have discussion in your local population, and it has to be accepted, yeah, as a general rule that we followed, and as yesterday was said, it can be grounded in faith. Yeah? It's important that it really addresses the feelings of the community. And there is a lot of research about the readiness to disclose child sexual abuse, and it depends on the open ear of a society. Yeah? And if there is no one who wants to listen to that, yeah, people will not disclose. And that is very understandable, because they want to stay safe. They don't want to be harmed again. And we have language in migration. We have a special vulnerability because we have language barriers, mistrust of institutions, and legal insecurity. So we have, in the cultural meaning of trauma, a victim's perspective. And there is one term that I find very interesting for our discussions. It's the cultural betrayal trauma, because in intercultural violence, abuse becomes another meaning if you are from a minority group and are abused in a country, because it's also an attack to your group. And yesterday, people told about, if you, in the discussion we had in the evening, if you are from a minority group, you don't want to think the others that we are bad. If Christians are in a minority, there's a high level of secrecy of talking about these problems, because to the outside world, you don't want to show these weaknesses. Yeah? So this cultural perspective is always very important. My field, psychiatry, has a accumulation of risk factors, as we also have people that we have to treat against their will. Yeah? Therefore, psychiatry is also political and cultural sensitive. And this I will mention later. But when we take transcultural psychiatry as a framework, we see that one universal model of psychiatry is insufficient, and clinical practice is not culturally neutral. But anyhow, we need translation of instruments if we want, for example, monitor safe upbringing, growing up without violence, like the Sustainable Development Goals say all over the world. We need questionnaires that are applicable in every state of the world to see whether we are moving forward or whether we have more abuse now with the new technologies. Yeah? So it's always a quid pro quo. But in some ways, you also have chances. We had Tom Osborne as one of our keynote speakers at our last conference of my European Society of Child and Adolescent Psychiatry. And he established with very low cost a stepped care approach to youth depression in Nigeria and proved that it's very, very, very effective. So he took Western principles from behavior therapy and combined it with the local infrastructures and found a very effective and very good solution. Yeah? And I think that's very creative. And in psychiatry, we often have an overlap, and there is research on transcultural psychiatry, and there's talking about transcultural safeguarding, but that intersection of psychiatry, of the medical field, and safeguarding, I think we don't talk enough about. And that's what I wanted to say this morning, that for me as a physician, it's very important. And for example, an American psychiatric diagnostic tool like the DSM-5, it's a statistical diagnostic manual, defined a cultural formulation interview. So where they really give you the hint, and if I look to Peter's 10 Commandments, it's about speaking, it's about listening and understanding also the social background. If you want to help a patient, you really have to listen, and you have to create an atmosphere where you can understand. So the things we talked about yesterday in the evening are universal to a transcultural approach that goes beyond language barriers, that has in mind the cultural differences between interviewers or doctors and patients. And if psychiatry is seen as a safeguarding actor, it's also important to discuss about who defines risk in this field. Yeah? And there we have to include our patients, and there we have to have a risk analysis that comes from the local culture and that builds on the expectancies you have on the services. So I think I will have to come to the end. We had a workshop here at the Greg, and I will tell you a bit about when I introduced to the poster sessions. There was one thing that was mentioned, that often there is no argument when the doctor says something, a nurse can't say anything. So we have in medicine a lot to do with hierarchies. And that might also be a bit similar to the church. So how can we empower the whole team to speak up if they see something what is difficult? So power is a central safeguarding issue. And often you have different layers of power. For example, in a Catholic hospital, there might two positions of mighty people, the church people and the doctors. And there are two hidden hierarchies, yeah, that compete. And you have to be open to speak about that. I come to the conclusion, I think there is that tension between universal rights and cultural praxis. But I agree, as a man from the West, grown up in the Western culture, I think there is also a benefit of these common standards, because that makes our practice reliable and gives a picture in your mind what everybody expects from a doctor. And we need context-dependent safeguarding. We need to value local perspectives. We have to address power dynamics that might be very special, and we have to try to understand it. And we need a reflective ethical practice, but I still think that what is written in the Oath of Hippocrates, it is still true also for intercultural services that we have now, there is no mean to relativize these general principles of doing no harm, of helping patients. So this is very important, and I thank you very much for your attention. And you see, we not only have still the highest church tower built of stone, because Sagrada Familia is only built of concrete. We are also very proud about Albert Einstein, but he only lived in Ulm for 6 months, for his first month. But as child psychiatrists, we know how early childhood is important for all our life. Thank you.